So to assess the extensor compartments of the wrist, we're going to have the patient relaxed on a pillow. We're using the high frequency hockey stick probe. The first landmark to find that's really important just to start orientating exactly where you are is Lister's tubercle. And you can see the Lister's tubercle pointing nicely there. Now, if we go medially on the wrist, we can get to extensor compartment 2. Now, this is extensor carpi radialis longus and extensor carpi radialis brevis, and that's extensor compartment 2. If we go round to the radial side of the wrist, now this is where we can get quite a few anatomical differences and variations, but if we have a look here, we can see that we've got abductor pollicis longus, which is where the arrow is, and we've also got extensor pollicis brevis, and sometimes you just need to follow up and down. So extensor pollicis brevis is the small tendon on the right hand side, and in this case, as we go distally, you can see that abductor pollicis longus actually has multiple slips, which is not uncommon and something to look out for. It's difficult sometimes to differentiate whether this is pathogenic or whether this is just normal anatomy. You can see the retinaculum going over the top. So extensor compartment 1, extensor compartment 2, and if we go back to Lister's tubercle, we see this little groove there, which is the extensor pollicis longus, and it sits in its own little groove just to the side of Lister's tubercle. If we keep going, the next tendon there is extensor indices in compartment 4, and also then we've got extensor compartment, in extensor compartment 4 we've got extensor digitorum. Now if we have a look on top of the radius, you can see it's got a nice thick retinaculum, which is normal, and you can see the tendons move as your patient wiggles their fingers. If we go to the next landmark, which is the scaphoid, which is the radial ulnar joint, so that's the distal radial ulnar joint, you'll see a little tendon on top of that, which is the little finger. So you can always just get your patient to move just to assess that, and that's compartment 5, which is extensor digiti minimi. Now, right over the side of the ulnar is our last compartment, which is compartment 6, and that is going to be the extensor carpi ulnaris. Now you can see it's got a nice thick retinaculum over the top, and if we go back more proximally, you can see that it sits in its own little groove just there on the side of the ulnar, and we can follow that down to assess the tendon. Now if we go back to our landmark, and obviously at any point you can spin into longitudinal section for assess. Now let's go back to our landmark, which is Lister's tubercle. Now there's 2 intersection syndromes that we need to be aware of. So let's start first of all with the first intersection syndrome, which is where extensor carpi, so extensor compartment 1 moves over the top, and we can see there it moves over the top of extensor compartment 2. And that's your classic intersection syndrome, or sometimes called the proximal intersection syndrome. Now, the second one is the more distal intersection syndrome. So if we find Lister's tubercle, you can see EPL there. And if we follow EPL down, you'll see that extensor compartment 3, which is EPL, goes over extensor compartment 2. And that's where you can get this distal intersection syndrome. Now, going back to the Lister's tubercle, which is our landmark, there's 2 things we can do from here. The first thing I want us to do is to assess the scaphoid lunate ligament. We can see the nice dorsal scaphoid lunate ligament if we just slide more distally off Lister's tubercle and our eyes go underneath. We see what I think looks like the AC joint, which you can see there. So look for any fluid there, any thickening of the capsule. And we also do a dynamic test at this point. So it's important to do it passively, and you just move the patient's hand into ulnar deviation. And as long as those bones don't open up, then we can say that that's a stable scaphoid lunate joint. Next thing we do is we go back up to Lister's tubercle, which again is our landmark. And then if we just spin on Lister's tubercle, then we can end up with a classic sort of view of the wrist joint, which is where we can see the radius on the right hand side of the wrist. You can see the lunate bone in the middle, and then you've also got your capitate bone there. And what we can do is we're looking very carefully for any synovitis or any joint effusions, and we can individually assess these joints. It's also really important to look out for any erosions in the joints, because obviously the wrist can be a region where you get systemic inflammatory problems such as rheumatoid arthritis. So this is called a standoff technique. Now we're going to show it to you on the wrist because it works well here, but actually it also works very well for lots of small joints in the hand and in the foot. It's particularly useful where you've got quite clear bony contours, and what the gel does is it fills in those contours to allow good contact between with the probe to ensure that you get a good image. So what we've done here, and obviously you need to use sterile gel, but what we've done here is we've built up the gel on the probe, and this is called standoff. So what you can see is, and this is why it's called standoff, you can see the gel in the image. And obviously this is the target here. So you can see the articular cartilage. So what you can do, and again, obviously it has to be sterile gel, is you can actually put the needle in and you can see the needle and the needle tip in the gel. Now that's got a few advantages, but one of the main advantages is you know what trajectory you're going into when you're about to pass through the skin. So you can see where the cursor is, and that will allow you to make sure that as you go in at a certain angle, you know you're going to get to your target tissue. But it also means that the joint is more open, so you can get the injection in a little bit easier, and often makes the whole procedure less painful for the patient. So as we go through, you can ensure that you're at the right angle, so you can see the needle there, and that will go in at the right angle, and you can just pierce the skin. To assess the flexor tendons of the wrist, the first soft tissue landmark we can identify is the pronator quadratus muscle, which sits here between the radius and the ulnar. Now, if we look at the tendons first of all that sit most superficially, now not everybody has a palmaris longus, but we can see a palmaris longus here. And next to that, more radially, we can see flexor carpi radialis. And remember, at any point you can follow these tendons down. If we move towards the ulnar side, you can see the flexor carpi ulnaris tendon, which again we can follow down. You can see the muscle belly getting smaller onto the attachment of pisiform, which is just one of its attachments. If we move back up proximally and we move more centrally, then we can start to pick up the median nerve. If we move more proximally, the median nerve is the structure that will find its way, there we go, dropping deeper into the forearm, and we can follow that median nerve up and into on top of the pronator quadratus that we saw earlier, tilting the probe because obviously they are quite prone to anisotropy, and we can follow that down. And if we keep an eye on that nerve tilting the probe, we can see as the flexor retinaculum over the top, and then what we're looking for is the scaphoid on the radial side, and we're looking for the pisiform on the ulnar side. If we follow it further down, if we tilt the probe, we can see a nice image there of the median nerve, and as we keep going down, we can actually see this very thick band here, which is the transverse ligament. If we go slightly more proximally, then we can see the nerve, and underneath this we can see lots of tendons, and if we get the patient just to wiggle their fingers, we can see we've got superficialis in the more superficial layer and profundus. But we also have another tendon that sits just underneath in this little corner here, which is flexor pollicis longus, and actually we can follow that down all the way into the thumb if we want to. If we go back up, the next structure that we're going to look at is we're going to look for this little triangle here, which we can see, which is Guillon's canal. So this is the pisiform. We can see the ulnar artery, and we can also just see the ulnar nerve. And if we're really light with our pressure, we can see a little vein pop out there. And then we can see that, follow it down, and then the ulnar nerve will split just above the hook of hamate, which we can see there. So those are all the structures within the flexor region of the wrist.
We're going to show you the medial nerve and how it goes into the carpal tunnel. So we start in the forearm, we identify the medial nerve in its fascial plane, keep it in the middle, and we trace the medial nerve distally. And you can see it starts to go more superficially. It becomes a bit hypoechoic, but you can change the angle, of course, and it wraps around the tendon, so it becomes superficial to the tendons just before it goes into the carpal tunnel. Now it lies on top, and now we're getting into the carpal tunnel itself. So we've got the ulnar side is on the left side here, and we can identify Guillen's canal there. It has an artery, vein, and a nerve in there, which is only a little compartment. Then we can see the retinaculum all the way to the radial side, and then we identify the medial nerve again into that compartment. If the patient wriggles their fingers a little bit, then you can see the medial nerve has a different moving dynamic than the tendons on top. You can spin on it, and the medial nerve again lies superficial to the tendons and is normally a bit more hypoechoic. And if you wriggle your fingers again, you can see there's a different dynamic to that. And in longitudinal, you could trace it outside, more proximal to the carpal tunnel, or a bit more distally to the carpal tunnel in longitudinal. And that is the medial nerve in the carpal tunnel and the flexor tendons around there. That's how you assess the medial nerve into the carpal tunnel.